Welcome, everyone, and thank you for joining us for our discussion on the South Sudanese Women Intellectuals Forum. My name is Dr. Anne Lomole. I am a pediatrician and an infectious disease consultant, and I will be your moderator for this session. Now, October is Breast Cancer Awareness Month, and our panel today will be discussing aspects of prevention, diagnosis, management, and life after cancer. We're grateful to be joined by our panelists today, and we have a few panelists joining us from East Africa, Kenya specifically, and we are honored to have them on this panel and on this platform for the first time. Breast cancer is one of the leading causes of cancer in sub-Saharan Africa and is a leading cause of mortality from cancer in women. Some of the reasons that have been given for this is delay in diagnosis, the lack of focus on prevention, and issues with availability and accessibility of specialized care and treatment services. Most women present with advanced disease, and because treatment options are limited, they have poor prognosis. Of note is that breast cancer can also happen in men. Delay between symptom onset and health-seeking behavior is an issue. In a country like South Sudan, and in fact, sub-Saharan Africa, where health systems are not well established, it becomes difficult for diagnosis to be made early and for treatment to be initiated. Now, focus for South Sudan and for sub-Saharan Africa must therefore be put on creation of awareness and prevention in order to prevent progression to end stage without ignoring the need to improve health services, to offer treatment and interventions for those who are affected, and also developing and training specialized human resources. And this starts with educating the public on self-examination and on signs to watch out for, and the use also of investigations for early detection. Today, we will discuss the epidemiology, the risk factors, public health interventions, diagnosis and management of breast cancer. We will also talk about life after cancer, and we are privileged today to have someone with us who will be able to talk us through her journey. We hope with this discussion, we'll be able to educate the public on breast cancer and discuss some of the challenges and barriers to treatment and management and possible solutions. So we're currently streaming live on Facebook and YouTube, so please feel free to share the discussion on all your social media sites. And we will be receiving questions also from the public, so feel free to post them on our Facebook page. We will answer them if time allows, and if it doesn't, then our panelists will go back and answer when the discussion is over. I would like to thank the audience for joining us today, and we hope that we will be able to demystify some of the issues surrounding breast cancer. I will go straight ahead and start the discussion by introducing our panelists today. First, I would like to start by introducing Dr. Kanyang Modi, who is a graduate of the University of Juba. He has worked and continues to work in areas of women's health, including family planning services, sexual reproductive health, and maternity services. He's also a public health practitioner and has a Master of Public Health from the Hebrew University of Jerusalem, Israel, and he's a women's health advocate, passionate about educating the public and creating awareness on women's health issues. Next, I would like to introduce Dr. Beryl Aquino, who is a graduate of Nairobi University, where she obtained her undergraduate degree in medicine and surgery in 2009. She also obtained her fellowship of the College of Surgeons in General Surgery in 2016 in COSEXA, which is the College of Surgeons in Eastern, Central, and Southern Africa. Dr. Beryl is a general surgeon and has an interest in breast surgery, and she's also the Assistant Program Director for General Surgery at COSEXA in AIC Kijabe, where she also works in Kenya. The next panelist I would like to introduce is Dr. Kokad. In absentia, he's having a few issues with his internet at the moment. I hope we'll be able to get him, but if not, then we will request him to record some of the answers he would have had for this session. He's a graduate of the University of Juba and obtained his MSc in Tropical Medicine and International Health from the London School of Hygiene and Tropical Medicine. And he's been involved in managing multiple primary healthcare programs as a deputy team leader with the Norwegian People's Aid and as a lead agent for delivery of basic package of health services in Central Equatoria State. He has been a project manager for the World Bank-funded Rapid Results Health Project and recently was the lead consultant for development of the strategic plan for malaria control. He is a public health specialist with many years of experience in management and delivery of health services, and he is to discuss the public health aspects related to breast cancer. Rose Mureithi, joining us from Kenya, is a registered nurse who has extensive experience in pediatric nursing. She's also a certified lactation and breastfeeding counselor. She's a daughter, a sister, and an aunt, and she is an entrepreneur and the founder of the Bethel Wellness Center. She she focuses mostly on pediatric healthcare, and she is a humanitarian and a philanthropist and an upcoming author. She is a breast cancer thriver and a child cancer advocate and volunteers for an organization, the Little Pink Smiles, that advocates for children with cancer and supports their parents and guardians. Finally, I would like to introduce Dr. Melvin Sindani, who is a graduate of Kampala International University, a medical doctor by training, a medical doctor by training. She is currently a pathology resident in the University of Nairobi. We have Dr. Kwaj joining us on speaker. We will talk to him as we go by. She is currently a pathology resident in the University of Nairobi and works at Kenyatta National Hospital, the premier referral hospital in Kenya. And she's also a director for the St. Irenaeus Medical Services in Nairobi. So I will go straight into the discussion. We will start with Dr. Kanyang because he'll be talking a bit about basic knowledge and the situation in South Sudan. So Dr. Kanyang, for the sake of the public and those who have no idea what breast cancer is, could you please define what breast cancer is and tell us a bit about the epidemiology and prevalence of breast cancer in Africa and the world and how it compares to South Sudan? Dr. Kanyang.
Hello. Thank you, Dr. Ann, for the great introduction. And I want to say to all those who are watching us or listening to us, I will be very brief and very simple so that you understand what we are talking about. So I would like to give this scenario like a kind of building a house. So usually when you build a house, you use bricks. And if those bricks happen to have problems, now our bodies are built with what we call as cells. These cells sometimes develop some problems also. And if they are together in a group having a problem, they form what we now refer to as a cancer. So simply it means that cancer is a group of cells in our body that can form a swelling, all right, or a mass in the body or a lump in the body, which has different function and more an appearance or morphology when looked under the microscope. So that is a cancer. Now, when we say breast cancer, it means this type of situation or a condition that specifically occurs in the breast. And when we say breast, it does not differentiate between a male breast or female breast. Both a male or a female can have breast cancer. Although then the difference is in the prevalence or in the occurrences of those cancers. So, like we can say that almost about a number of cancer occurs in the whole world, and basically we are talking of numbers that are very high, like almost about uh, okay, so I'm getting a little bit of messing up things, but I'm trying to say that in the whole world there are more than more than, okay, give me a second to look into my notes so that I can get you clear. Yeah, so I'm saying that in the world, there are many, many women that are suffering from breast cancers, including up to about 85% of those breast cancers are called epithelial cells cancers, and about 15% of them are occurring in what we call as lobules, or those part of the breast that usually uh, from the what? The breast. The the different parts of the breast that forms the describe that about we are saying that about over 20 let me see it again, we are talking of about 200 or 21 people per 100,000 of population. 21 people out of 100,000 of people have what we consider as cancer, particularly when we look into South Sudan. In the whole world, of course, the numbers are very high in millions that are infected, and also over hundreds that are having deaths occurring because of the breast cancer. I'm wondering where is my data, and sorry for that. However, I'm going to get back to you. So basically, it means that breast cancer can occur to any lady or to any gentleman at any age. At any age, it can happen. So please, and if you think I'm talking more than what you expect, let me know because I can talk as
Thank you,
much
Dr.
as I
Kanyang. I
can.
think
Yeah.
that's
So
fine. Thank you so much. I think you've basically set the stage because you've explained what exactly cancer is, and the fact that it's breast cancer just indicates the location. In terms of the epidemiology, you have indicated that both men and women can get breast cancer because they both have breast tissue. Also, women are definitely disproportionately affected. And maybe the statistics in South Sudan and even in truth in sub-Saharan Africa are an issue to get because we don't have very, very good cancer registries. And of course, we are also missing out the
that's
people who
right.
don't come to the medical facilities for us to even record that they have breast cancer. And some of them end up passing away wherever they are without ever coming into contact with medical professionals. And there's a tendency, even for many of them, to seek help from traditional healers. And that, of course, then increases the progression to end stage disease and metastases that might end up causing mortality. So thank you for that. I think it's difficult to get
And
statistics from South Sudan specifically also because of course we know our situation in terms of our healthcare system and even our data collection mechanisms. So I will ask you the next question, Dr. Kandian. What are some of the risk factors for breast cancer and what are some of the prevention
yes, but in
strategies?
reference,
Yes. Yes, Dr. Kandian. Okay. So what I was asking is that what are some of the risk factors
thank you.
for breast
It's
cancer
okay.
and
I
what
get
are
you.
some of the prevention strategies for breast cancer that have been found to be most effective, either in early detection or in prevention of progression? Dr. Kandian.
Very good. Yes. Are you getting me?
Yeah, Dr. Kandian, loud and clear. Go ahead.
Yes. Yes. Only that there is a background noise. I don't know where it's coming from, making some disturbance to the ears. So, as I continue, I just wanted to add to your comment on the statistics in South Sudan. That's very true. And indeed, we see on WHO web pages that South Sudan is number 35 in Africa in terms of breast cancer occurrences. That means that we have more occurrence of breast cancer in the country than we are able to recognize or diagnose. So, in terms of the risk factors, of course, some of them include um, risk factors that we can change and risk factors that we cannot change. Now, the risk factors that we can be able to change, okay, include things that are things we can do by ourselves, such as not being physically active. This is a bad behavior if we are not physically active. it is something that can lead into development of some changedom, of course. So we need to be active. We have been overweight or obese, or particularly after menopause, when a woman is at the age after her menstrual cycles have stopped, or taking of hormonal drugs. Those are things that can be avoided and we can change them. And then also reproductive history, like having the first pregnancy after the age of 30. So young women that are not yet able to get children should be encouraged to have their first babies at least before the age of 30. And also drinking of alcohol. This is one thing that we can be able to say, because it has been noticed that women's risk for breast cancer particularly increases with the more alcohol that they drink. Now, these are factors that can lead into breast cancer development, but we can be able to change them. Then, what are those factors that we cannot change? All right, these are things including our process of getting old. We cannot change it, of course, and it has been known that many women get diagnosed with cancer after the age of 50 years. And then also something called genetic mutations. This is a change in the genetic component of our body cells, which I actually started explaining with earlier, that if our body cells change to have being a different structure that was intended to be, they will form what is called as cancer cells. Now, another thing is also reproductive history. Like when a lady starts menstrual cycles at the age before 12 years, and then starting menopause after the age of 55 years, these are things we cannot change, but they are also considered risk factors for developing breast cancer. Another one is having dense breasts. And this means simply that when the breasts are a little bit, or they are bigger, or when people call it big boom, okay, they are big and they are dense. So they have a lot of fat tissues, they have a lot of lobules or larger lobules that we were talking of in the beginning. This could be a risk factor for the development of breast. And of course, a woman cannot change that. Personal history of breast cancer or certain non-cancerous breast diseases. When you have diseases that infect your breast, or other history of breast cancer in the family, change. Then, if you have it, you need to follow up what we are going to describe for you for monitoring the process of which you can understand that something is not right on your body. All right, radiation therapy. If somebody gets a disease that gets treated using ultraviolet rays or radiation therapy, this would sometimes cause change in the genetic components of some of the cells, and that can lead into development of cancer in life. Then the last part of things that we cannot change is when women put or diethyl stilbestrol. This is a form of hormonal medication that some women get, taking it for some reasons to treat them. But this drug can also be a reason for developing cancer later on in life. So these are some
Thank
of
you.
the risk factors that we should look at. They are either we can modify or we can change, or they cannot be changed by us.
Okay. Thank you, Dr. Kanyang. So prevention actually involves a bit of focus on the non-modifiable factors in order to decrease the risk. But of course, there are non-modifiable factors that you cannot change. The fact that you're female, the fact that you have a genetic predisposition, those you cannot change. Now, Dr. Kanyang, what is screening for breast cancer and what does it involve and why is it important? And after you answer that question, could you please just give us a brief overview of some of the signs and symptoms to watch out for when it comes to breast cancer and when one should seek medical intervention before we move to Dr. Melvin? Screening for breast cancer and signs and symptoms to watch out for. Dr. Kanyang.
Okay, so yes, thank you very much. And this is a very important question. Generally, let us realize that screening for breast cancer can be done in the laboratory using what we call as cancer or tumor markers. That is something that involves the medical center with a better laboratory facility to be able to do that. The other thing that is very simple for us to do is, of course, once you notice that you have or any other type of cancer, it is important for ladies or even men to be aware of their breast and know any other type of something that wasn't there previously. I am talking about things that you can feel on your breast, including a swelling, even if you don't feel it painful. It is very important that you go to attend to a doctor who can be able to look at it properly and give you a better diagnosis of what it could be. It is important for us to know that cancer tissues or tumors are usually non-painful at the beginning, but they become painful when they have developed into a higher degree or higher classification, because we classify cancer into either primary, secondary, or tertiary. Okay, painful, you can get treated, you can get cured, as you will hear later on in part of this session. Now, ladies do a very gentle examination of their breasts, palpating it all round and then in the middle by the beginning of every period. I mean, by the beginning of every menstrual cycle, that could be a very good reminder for this lady to do an examination that we call it self-examination of the breast cancer. And it is not difficult. You can simply take your breath and then coming to conclude by pressing the middle back down against your ribs. If you feel anything that is feeling firm or hard, even if it is not painful, you need really to see a doctor immediately for an early diagnosis of anything that it could be. I am not sure if I have responded to all the questions.
Thank you, Dr. Kanyang. I don't know if you had mentioned some of the signs and symptoms, the lump, the change in the skin, some discharge from the nipple. Some people can actually feel swelling inside near their armpit. I think you had mentioned some of that, right? The signs and symptoms. So that's fine. What we will do is we will now go to, thank you, Dr. Kanyang, for that answer, and thank you for also describing how an individual can actually self-examine and determine whether there is a lump in the breast, and then therefore then that triggers them to seek further investigation. So we'll go to Dr. Melvin, who is going to talk a bit about the pathologist's role when it comes to breast cancer. Dr. Melvin, what is the pathologist's role when it comes to breast cancer, and how is breast cancer diagnosed? Does it differ among different age groups? And then you can mention a little bit about genetic counseling, especially in people with family history of breast cancer, because Dr. Kanyang has talked a little bit about the genetic predisposition. What happens to those individuals who have a family history of breast cancer? What are the recommendations?
Okay.
Dr. Melvin.
I can start with ask what is our role. So, what we usually do with this or a tissue biopsy from then we
Dr.
examine.
Melvin, I don't know what the issue is, but I cannot hear you clearly.
Can you hear me now?
Yes. And
Okay.
there's some background noise. I'm not sure from where. So I'll just mute myself.
No. Let me
Okay, just
check it.
go ahead, Dr. Melvin.
Okay. So, can you
If
hear me
you do
now?
not unmute, you can try and mute yourself.
Can you
We can
hear
hear
me
you
now?
clearly. There's just some background noise, but we'll figure out where it's from. Go ahead, Dr. Melvin.
Okay, so our role as pathologists in breast cancer is that we normally give the diagnosis of breast cancer. So how we do it, we usually receive a specimen from the surgeons or a tissue biopsy from the surgeons. Then we examine it under the microscope and we make the diagnosis of breast cancer and if it has spread to other tissues or it's just limited to the breast. Then, as we know, tumor cells usually produce some kind of proteins. So, as pathologists, we determine the kind of proteins that the tumor cells are producing so that the oncologist can know which type of radio or chemotherapy they can give to the patient. In short, we also assist in treatment of breast cancer. How does it differ between age? Okay, so normally breast cancer occurs normally in people who are elderly, 40 years and above. For younger people between 20 to 30 years old, we normally see benign cases of breast cancer, not the malignant cases seen in older women. Then what else? It also depends on the genetic mutations the individual is expressing. So that is also one of the reasons why pathologists get involved so that we know if there is genetic involvement or not. So how we do it is usually breast cancer usually involves the BRCA1 and BRCA2 genes. So we screen if the patients have it or not. Then it's called risk assessment. We tend to evaluate if you're more susceptible to getting the breast cancer, to developing breast cancer in the near future or not. And that involves also the modifiable characteristics Dr. Kanyang was talking about, the ones you can modify and the ones you can't modify. So what genetic counseling do is we answer the questions of, do I have the risk of developing it or not? If I have it, what do I do next? Do I modify my lifestyle or not? Do I undergo surgical preventive measures or not? Or also, do I just live my life the way it is and battle the cancer if it comes? So that is what genetic counseling involves. I think I've answered majority of your questions.
Thank you, Dr. Melvin. Yes, you have mentioned about the mutations that are looked into, and for those who are at risk, they are offered certain treatment options. And I think Dr. Beryl will also talk a little bit about that. For some, they're given what we refer to as prophylactic mastectomy. For others, they can decide to go on a medication for a few years. We'll discuss that a bit further. Now, the other thing I wanted to ask you, because the pathologists are very, very involved when it comes to diagnosis, what are some of the different classifications of breast cancer and why is it important to classify? This is according to pathologists. Why is it important?
Okay, so breast cancer can be classified. It's a huge list, but let me try and summarize it as much as I can. So cancers can either be benign or malignant. So the benign ones usually easily treatable. You just remove the cancer and you're done. But the malignant ones are the ones which causes a lot of issues in the long run, which can be further classified into invasive and non-invasive. So invasive means the cancer spreads from the stomach to the rest of the tissues, from the breast to the rest of the tissues. So it can go to your lungs, it can go to your stomach, it can go to your brain, it can go to anywhere, any part of the body. For non-invasive means it's limited to your breast. It's just inside your breast. So for the invasive ones, there are two major ones. There's the intraductal and the intralobular. So the ductal means it's in the ducts where the milk usually, it carries milk to the nipples. While the lobule means it's where the milk is made. That is where the cancer is starting from. So those are the two invasive ones. For the non-invasive, it's a whole list, but let me start with a few. It can be a fibroadenoma, which is usually a small lump, and it's mostly in young women. It can be cyst, it can be a galactocele. It's just something benign, something that can't harm you in the long run as invasive does.
Thank you, Dr. Melvin. Now, when it comes to what you see under the microscope as a pathologist, what are some of the things that determine prognosis and outcomes when it comes to breast cancer?
Okay, so for prognosis, we usually look at three things. So number one, we usually look at if it's premalignant. If it's a premalignant lesion, it means you have a 4 to 5 times chance of developing malignant or invasive breast cancer in the long run. So that is one of the things we look into. Then if it's a non-invasive and it's limited to one area of your breast. So when we look at it under the microscope, there are some things we look at, maybe the nuclear grade, how it, we say morphology, how it looks like. So if it's, the morphology can be either chamido or non-chamido. So chamido means it's a flower-like appearance. So if it looks like a flower-like appearance, there's an increased chance of you developing a recurrence of it and developing into a malignant thing. Then if you're undergoing any type of hormonal replacement therapy for any other condition apart from breast, there's an increased risk of developing breast cancer. Then if you have the BRCA gene and you've decided to do conservative therapy, that means let me stay and see how life goes. You have an increased risk of developing breast cancer and your prognosis will be poor. Then we also look at if it's an invasive breast cancer, how it looks like under the microscope. Are there lymph nodes involved? If there are lymph nodes involved, then your prognosis is poor. If the tumor size is large, then your prognosis is poor. If there's any other biological indicators, for example, when you look at something called immunohistochemistry, so there are some receptors we are looking at. If it responds to estrogen receptors or progesterone receptors, so if it responds to it, then your prognosis is good. If it doesn't respond to it, so your prognosis is poor. Then we also look at, I've already said lymph, we also look at, there's something called oncogene dysregulation. So this means when your body is trying to fight off the cancer genes and your immune system is not responding as well as it's meant to be. So it also gives you a poor prognosis as compared to somebody whose immune system responds better. So thank you.
Thank you so much, Dr. Melvin. You have explained quite simply a very complicated question. And thank you for that. I think the people listening in now have an idea if you're looking at those results and you're trying to figure out what do they mean by mitosis and whatnot, you're able to tell that depending on what is seen under the microscope, that will determine your prognosis. When you have lymph nodes, those are the things that swell when either you have an infection or a tumor. that also determines your prognosis. Whether it has spread to other sites, that also determines your prognosis. And that is why it's important for us to emphasize on early diagnosis and early intervention so that we don't get to that stage. Now, I'll move a little bit away from the very medical talk, and we'll go to Rose, who has gone through the journey and is thriving. And she keeps on telling us it is thriving, not surviving. And that's an amazing, amazing word to use. So, Rose, tell us a bit about your journey. How did you find out about the diagnosis? What was your first reaction? And how did you cope? And maybe you can also tell us a bit about some of the options you were given for treatment and some of the side effects you experienced before now we go to Dr. Beryl, who will give us exactly what they usually tell people who have been diagnosed with breast cancer. Rose.
Thank you so much, Doc. And thank you for having me. I'm a believer of telling my story so that I can be able to help somebody somewhere. And a story never told just remains a story. So let us tell our stories. So it was in 2016, January. I think it was my New Year gift. So I was just, it was on the 9th of January. I was just in the bathroom taking my shower. And I just felt like it's when you're expecting your periods or that, and then you feel your boobies are a bit tender. So I just touched. So I just decided to do my own self-breast examination. And kaboom, I felt something on the left boobie. So I continued with the right one. And then I went back and still touched the site, and I felt, yes, for sure there is something. And now being in the nursing profession and being a nurse, and I just felt like I think I kind of know what is going on, because it felt just the way it feels, the hard bean. I usually describe it like a bean or a piece of maize. When you touch it, it's hard and it is not moving, it's just there. And it was not even painful, but it was more. So it's a roller coaster of emotions. I was angry, I was bitter, I was angry with myself. First, why now? And why me? And what could I have done wrong? What could I have maybe done for me to prevent this from happening? And so, it was just a moment. And it was a whole mix of emotions. And I remember sitting down on the floor of the shower and just crying and screaming. And right that time, I'm alone in the house. But I gathered myself and I went to work, never told anybody what is happening. And then afternoon, I decided to go and visit the doctor we used to see with our insurance. And I went to see him, and I was kind of angry with him or her, whoever I was going to meet. Because in November of 2015, I had visited the same clinic and told the gynecologist, I requested for a gynecologist checkup, because I've never done one, but I had been doing pap smears and they were okay. But this time around, I needed somebody to touch, to touch me, to check and to look, to find something. And he didn't. He just checked and so, Rose, you have been doing pap smear? Okay. No history of cancer? Okay. So you are good to go. Go. So this time round, I went and requested I need to see a gynecologist. And funny enough, I found the same guy. So when I got in the office, in fact, I remember I just looked at him and told him, I'm not even going to undress. I'm going to open one button. You put your hand through this button and touch and tell me what I felt, whether it's what you think it is. And he asked me why. I told him, if you don't remember me, I was here. I asked for a checkup. You did not do anything. So just do what I'm telling you now. Remember, I'm angry. I'm a very angry person. The emotions. So he checked and he said, yes, I felt a lump. And he goes down and scribbles a note and tells me, now I'm going to refer you to a surgeon. So I asked him, a surgeon? To do what? So that he can remove the... I picked the note, tore it off, dropped it at the door, and walked out. Angry and crying. So I got in my car and I went there and just decided, what can I do? I called one of my friend, a doctor, a pediatrician, and I shared with her what I'm going through. And she told me, no, don't go and see a surgeon. On Monday, go share with your boss, who happened to be a pediatrician, and Dr. Nesbitt, and we'll see what he can do to help you. So I went, I shared, and so the Dr. Nesby told me that we are going to see what we can do. So he referred me to a gynecologist in Aga Khan Hospital, who went and did the usual, checked, and finally there was the ultrasound, there was the mammogram. Mammogram confirmed yes there is something, and then there was a biopsy and a guided ultrasound, and then the checking and everything. A diagnosis came, kaboom. There is a breast cancer stage 1, grade B. All the tests done, anything, bloods and everything done, and it was stage 1, grade B. So I was referred to the surgeon, the breast surgeon, who at one point he advised me to do, after we did the surgery, we did the lumpectomy. Because after everything else was done, they found that it was just in the lump. It had not spread anywhere else. I think it was the duct there. So there were no lymph nodes, and even the margins were negative. So at least we discussed with the surgeon before we went in that if he finds that the margins are negative, he can preserve the breast. If not, then he can do the total mastectomy. But I'm happy that he did the conservative, that is the lumpectomy. So as I was hearing, he advised me to do a test that only could be done in Germany or America, USA, if I could afford. That was the Oncotype DX. It was a test to check the recurrence level of it, so that they can see how many chemos or what treatment, the treatment plan that they are going to give me. And so I was told the normal, I think it should be around 18 to 34 something, but mine came to 37. So that was high, the recurrence level. So they decided that they are going to give me chemo. So after the 6 weeks of the wound healing, and I think another 1 week, because there was a spot that was not healing well, I was put on chemotherapy. So I did 4 sessions of chemotherapy. And then because of the preserving of the breast, I had to do radiotherapy. So I did 25 sessions of radiotherapy. And remember, it was the estrogen positive. The type of the breast cancer was estrogen positive. So I was put on, after the radiotherapy, I was put on tamoxifen. That is the hormonal replacement therapy. So I've been on tamoxifen, that is the Novadex D, 20 milligram, 1 tablet every day for the next 5 years. This is my 5th year. So 2021, I'm celebrating 5 years of remission. But now, when I went for the last checkup, immediately you are done with the active phase of the treatment. You go for checkup every 3 months, and then you graduate to 6 months, and then you graduate to yearly after 5 years. So I've been doing all that, and the last checkup, we agreed with my oncologist, because of the Oncotype DX results, and even the current research that is still going on, I continue for 6 to 7 years. So I'm still popping up my tamoxifen every evening, 1 tablet, and so far so good. So the reaction of how I reacted to the diagnosis was, it is not an easy thing. One, you feel like you are dying. Of course, you feel that cancer, that cancer, that word itself, it's not interesting. You feel that you are going to die, or you're just finished. But I remember I shared my story, and then I got previous survivors or people who have gone through it. They shared with me, and they really helped me. They held my hand. One lady had survived by 2016. She was in her 13th year, and she had done a total mastectomy. So her whole booby was removed. And she told me, Rose, yours is just this. You're going to survive. So a fellow survivor, and many of them, they held my hand and they gave me hope. My family really supported me. My friends, my church groups. It is the support system that you get that really keeps you going. And so far, I can't complain, and I thank God for it. So the side effect, my hair went south, it fell off, and it fell with the first chemo. So by the time I was going for the second chemo, my head was bald. And then I had a black tongue. The tongue turned black. My teeth started misbehaving. In fact, after that, I lost 2 teeth. And then my nails and the toenails and the arms, they also went black. But all that, they came and everything wore out. In the last fourth chemo, by the time I was at the 4th month there, everything, the side effects had started to wear off. And of course, with tamoxifen, I'm being taken on menopause, night sweats, and the hot flashes. That is the worst, the worst side effects. Yeah, I usually say I sweat in July. When you are dressing up, me, I'm removing my clothes. So that is the main major one. But you know what? I always say it could have been worse. So it's just taking one day at a time and living to the full and giving hope and moving on with life. So there is life after breast cancer, or there is life after cancer. Yeah.
Thank you so much, Ruth, for sharing that part of your journey and even your reaction when you are first told about the diagnosis, because it's basically quite shocking, something nobody expects to happen uh, in their lifetime to them. But we are so grateful that you are able to share that part of your journey. Dr. Beryl has dropped off. Dr. Beryl. So Dr. Beryl has dropped off. We were going next to her. Dr. Kanyang, before you log off, Dr. Kanyang, I was going to go to Dr. Beryl, but we can finish with you. Dr. Kanyang,
Good. Yes,
yes, if
I'm
you could please
available.
just give us, before you go, just give us a brief overview of what the state of care for those who are diagnosed with breast cancer in South Sudan is and what can be done to improve it. And just give us a conclusion before you leave. Then we can go to Dr. Beryl if she's able to come back on screen.
Thanks a lot, and I'm glad to be part of this session today. It is a lot of learning, and I hope our listeners are indeed gaining and actually taking note. In South Sudan, you know, the state of care is really, as we all know, not to the standard that we could be expecting. We have a lot of things that are not available at the moment in the country. Our main referral hospital is having a lot of challenges that most of us know. We can't talk about it now. The major thing is that we need really to be able to identify any lump on our breasts as early as possible, so that if it is suspected, maybe you can have a referral to a country or to a facility where it can be better diagnosed. Because in country, I haven't seen any better or any form of proper diagnosis for breast cancer. Possibly, maybe our pathologist in country can do for us pathology. That is a possibility. But other than that, we are still backwards. How it can be improved? Of course, it involves a lot of stakeholders to work together, and most importantly is to have the a kind of an environment that is conducive, because we have possibly a number of brains that can be able to be here to do services for the people here, but they are kept outside because of environmental or stressors that are making them fear to come in country. And even there could be some people who would want to invest in bringing maybe those diagnostic systems and equipments into the country, but they are scared because of the situation we all know is in the country. So this could be some of the ways we need to work alongside with our government and encourage our government to ensure sustainable peace for a prosperous and peaceful South Sudan. Of course, in conclusion, before I leave, I want to say thank you all for giving me this opportunity to be part of this discussion. I loved it, and I hope to do another in the future in any other topic that I can be able to contribute. Otherwise, take care of yourselves and stay safe. Bye for now.
Thank you so much, Dr. Kanyang. We are grateful that you were on the session with us today, and we are grateful for your willingness always to come and talk about women's health and women's issues. And stay safe. Thank you so much for joining us. We'll go ahead to Dr. Beryl before we go to Dr. Kukwaj, who's currently with me on a WhatsApp call because he's not been able to join us on the platform. Dr. Beryl, I know Rose has talked a little bit about what options she was offered when she was given the diagnosis. Could you please tell us what are some of the treatment options for breast cancer? What surgical options are available? And in what cases would you advise differently? And you can also give us a few notes on some of the side effects of the various treatment options available and how they're dealt with. I know Rose has mentioned some, and what are those that those who are undergoing treatment should actually watch out for? Dr. Beryl.
Okay, thank you. Thank you very much for having me in the forum. Basically, breast cancer treatment is multimodality, which means there's no single method that's going to treat it. Usually, we use a combination of at least 2 to 4 different methods, depending on what Dr. Melvin had said, the pathology of your breast cancer. So generally, the methods that are available, we have chemotherapy, we have radiotherapy, we have surgery, and we have hormonal therapy. And I will keep referring back to Rose because Rose was able to receive all the 4 methods. So you can receive all the 4 methods. Some people receive 3 out of those. Others receive 2 out of those. But you can't receive one. You have to receive more than one method. So if we start with chemotherapy, that's basically cancer drug. Just like if you have malaria, you take anti-malarial drug. Chemotherapy is anti-cancer drug. And usually you can get up to between 4 to 8 sessions, depending on your cancer. The sessions are always 3 weeks apart. So you receive one today, you rest for 3 weeks, you get another one, rest for 3 weeks, another one, up to 4 to 8, depending on what your oncologist is the cancer doctor has prescribed. The major side effect that you have from chemotherapy, as Rose has mentioned, one is hair loss, because the cancer drug kills all the rapidly growing cells. Hair is one of them. Then the other thing is nails. You always have to clip your nails every so often. So also your nails can be damaged. Usually we counsel patients way in advance that this is likely to happen. So sometimes if you're not comfortable walking bald, we can advise you to acquire a wig just for that period of time that you're on treatment. After treatment, you always get your hair back. You get your nails back. It may take a little bit of time when your nails still look a little bit dark, but that should clear off. The other complication of chemotherapy, you usually get nausea and vomiting. Usually we give medication to try and prevent that. You can also get diarrhea from that, and you can also get sores in your mouth. But those are temporary, they're not permanent. So after some time, once you finish your chemotherapy, you should get back to normal. With regard to surgery, the immediate side effects of the surgery, of course, part of your breast has been removed or the whole breast has been removed. So you have you have a scar that has to heal. So you may get pain in the immediate post-op period, but once it heals, that goes away. The most common side effect of surgery is psychological, knowing that, especially if you have the whole breast removed, knowing that you've had your whole breast removed. How we deal with that is we get our clients into various support groups to deal with that. Then later you can get reconstruction, or what we have is a prosthesis. It's something you can put in your bra so that when you wear your clothes, nobody knows unless you tell them that I've had cancer, I've had my breast removed. As for radiotherapy, usually it's almost like you're using energy to burn that area where the cancer was. You may get pain in that area immediately during the radiotherapy, but that should go away. Then sometimes if part of your surgery was to remove some lymph nodes that were in your armpits, then sometimes some people get swelling of that hand. It's not common, but it's a complication that occurs. Sometimes we put on some pressure dressing on that hand so that you don't get those complications. But those are the most common complications that you can get. Then hormonal therapy, it's the easiest therapy of all those because it's one tablet that you take each day. Usually, if you're young and of childbearing age, then what we will advise you is you need to let your doctor know if you intend to get pregnant, because we will need to stop those medications during that point in time. But basically, if you're just taking them, you're not intending to have any children after that, then basically they have a very low side effect profile.
Thank you, Dr. Beryl. That was quite a great summary of what is done in terms of treatment options. From your experience, what are the outcomes post-treatment for most patients? And what determines progression of breast cancer? How can this be prevented? What are the outcomes and what determines progression to dissemination of the breast cancer, and how can that be prevented?
So the outcome is going to depend on the stage of breast cancer. So we have stage 1, stage 2, stage 3, and stage 4. Usually, we want to get your cancer in stage 1. That's why we recommend that you do self-breast exam, just as Dr. Kanyang had recommended. Self-breast exam. If you find a breast lump, come in early. We get it early, we treat it. So if we find you at stage 1, then we have we say 98% 5-year survival rate, which means if we find 100 women here today with stage 1 breast cancer and they've gone through all the prescribed therapy, then 98 of them should be alive and well and have not had any breast cancer. And that number is 95 at 10 years. So 95 of them will be alive and well. They've not had any problem again with breast cancer. Then for stage 2, it's 90%. So breast cancer is still a very good breast cancer because at 5 years, if you are at stage 2, 90% of women will be alive at 5 years. They've not succumbed to the disease itself and it hasn't recurred or it hasn't come back. Then if you are stage 3, now it goes lower to 66%. It means only 66 will be alive. The cancer may have recurred or the cancer may have killed them. So what we are trying in terms of progression or how is to prevent it. Check yourself. If you find any small lump, then you need to see a medical doctor or you need to see a surgeon or an oncologist so that you get the proper treatment early. About the progression, if you don't, the natural history of breast cancer is if you don't seek care, or if you do not follow through with treatment as prescribed by your doctor, then it's likely to recur or it's likely to continue growing. So once in a while, you find patients who the doctor has told them will take out part of your breast. Then after that, you need chemotherapy and radiotherapy. But once it's taken out, they disappear. They say, I don't want chemotherapy, I don't want radiotherapy. Those patients usually come back within 2 or 3 years because it means the cancer was not fully treated, so it's come back. So it's very important that you follow through with the treatment that your doctor has prescribed for you to ensure that it doesn't progress any further or it doesn't recur. Okay, did I answer all your questions?
Yes, thank you so much, Dr. Beryl, for that. Now, before I go to Dr. Kukwaj, who will tell us a bit about the public health issues associated with breast cancer, what I think Rose has talked a bit about it, about the post-treatment follow-up. What does this entail, and how long does it continue? Why is it important to follow up people who have been diagnosed with breast cancer and treated? And how long does this follow-up continue for?
Okay, so follow-up is very important. Dr. Kanyang had mentioned one of the most common risk factors for breast cancer is a personal history of breast cancer. So it means if I have breast cancer, I may get it again. That is why we need to follow up very closely. If it's going to come back, most likely it's in the first 2-3 years. So once you've had your full treatment, within the first 2-3 years, you have frequent follow-up. Then after that, you have yearly follow-up. So usually our protocol is the first year you get every 3 months, you're seen by your doctor, your surgeon or oncologist. Year 2, every 4 months. Year 3, every 6 months. Then after that, we go every year. Then usually we use a mammogram or sometimes an MRI. These are special tests to look at the breast, and it's just to see, is there any recurrence? And if we get it, we can manage it early. So you will get every year, your doctor would recommend either you do a mammogram or an MRI.
Thank you so much for that, Dr. Beryl. I think it's important to remember that even once you're treated, you don't disappear completely. You have to keep being checked because there is a possibility and risk of recurrence, and that has to be looked into by doing the various tests that you have mentioned. Now, I will try to get Dr. Kukwaj on the phone because he's been unable to join us. He's been unable to join us on the platform. So, Dr. Kwaj, you're currently on the panel. So I will go ahead and ask you some of your questions. I hope the public will be able to hear you. So we wanted to talk a bit about the public health impact of breast cancer. What is the public health impact of breast cancer, and what are some of the public health strategies that have been used in prevention of breast cancer? How can some of this be implemented in South Sudan? Dr. Kukwaj.
Well, thank you very much, Anne, and my colleague on the panel, and also, our audience. The public health impact of breast cancer, I hope you are getting me.
Let me ask the people on the platform. Just go ahead, Dr. Kukwaj. Go ahead. Go ahead, Dr. Kukwaj. We're listening. Aktari, if you can unmute yourself. Dr. Kukwaj, are you still with us? Okay, I'm going to have to call him back. Dr. Kukwaj, just go ahead. Go ahead. Dr. Kukwaj, It seems that the call is muting on and off. Okay, we'll call Dr. Kwaj a bit later. Let's just go ahead with the rest of the panel. And I would like to go to Rose next. Rose, you were telling us a little bit about some of the people who were able to give you support during this period of time when you were when you got the diagnosis and when you were on follow-up for treatment. And apart from who you have mentioned, what other support system was able to help you through this? And what would you advise those who are going through the same and are in and about, especially about the need for a support system, because many people want to keep the diagnosis a secret and therefore they don't even seek out other people to assist them? What would you say about support and the importance of the support system?
Thank you, Doc. I think I would say even when I'm talking to other people who are being treated for cancer, or when I'm talking to a group of people, I usually give them my protocol of treatment of cancer. It starts with faith. Okay, first of all, when you get the diagnosis, you have all the emotions as a human being, and it is okay. I usually say it's okay. Just let out those emotions out, because if you bottle them up, then even the treatment that you are going to get, it will not work. So I usually say when you get to the stage of accepting the diagnosis and then you seek help, so the treatment is going to start, be a person of faith. Be very, very prayerful. We all believe in the higher beings. So let's believe in God and be very prayerful. The third one is having a positive attitude. Like me, I'm a person who usually detect negativity from a distance. So when you have the positive attitude, even it is usually said even the happy hormones, they help you get well. So have the positive attitude and a fighting spirit. And then combine that. Now, when you have the family with you, your relatives, maybe your spouse or even your children, allow them to help you and allow them to support you. Sometimes we usually think that, now I'm being supported in terms of money, because a cancer journey is not cheap, it is expensive. So even my insurance wore off at some point, and NHIF could not pay anymore. And so I also needed the monetary support. So I realized that when you are going through this tough journey, there are people who are willing to help if you ask for help. So don't feel bad, don't feel intimidated to ask for help. So that is also a way of getting support. The other thing is the church people and your colleagues, the ones you go for fellowship with, and your church, and the fellow survivors. Always if possible, reach out to somebody who has gone through cancer treatment or the cancer journey, and they are going to tell you the facts. In fact, I usually say, I'll tell you what I went through, but in terms of chemotherapy effects, because there's so much information out there, everybody reacts differently. It does not mean because my hair fell, even your hair is going to fall. It does not mean because I had a lot of diarrhea with the first chemo, yours is going to be the same. No. Get facts and then just accept that something is going to happen and it will finish. The other thing is being afraid to your care system. The doctors, in fact, it's I usually call them my whole village of doctors. There is the breast surgeon, there is the oncologist, there is the chemo nurses, there is the radio oncologist. Be afraid to that whole care team. I realize that you have all the questions, including very serious ones, but the nurses will tell you, please, Rose, feel free, anytime call us, write for us a text and ask any question that you have. And they were very eager to help me, and we walked through the journey with them. And so have that people around you and allow yourself to be helped. Allow yourself to be vulnerable, because it's not easy. But I always say it is possible and it is doable. So seek help and just fight it and fight on and cling on. It is possible to fight it and get over it and move on with life. Yeah. So maybe I can just add a bit about now the life after the checkups and everything. I had to do adjustment like nutrition and the lifestyle. And because I was told one of the side effects of the tamoxifen is formation of a clot. So I don't want to die. Cancer did not kill me. So a drug is not going to kill me. So I started moving. I'm more mobile. I don't just sit. I started hiking. I hike every month, mountains, and going to nature. So even if you are going through cancer treatment or the cancer journey, find yourself something that you'd love to do, and especially nature. Please get out of the house, go to nature. Nature is healing and it is coming. Yeah.
Thank you so much, Rose, for that encouragement and for basically just being here to show that we can beat breast cancer. I wanted to ask you a bit more about the financial aspect. You had talked a little bit about financial support and how it became difficult at some point. How was the experience for you, and what advice would you have for others, especially before this diagnosis? What would you have done differently when it comes to the financial aspect of the treatment?
In terms of finance, I was lucky enough to have an employer who had a good insurance for his workers. So the insurance took care of the treatment part of it, because it reaches a point that they say now we can't continue anymore. So it finished the insurance. Then there is our national NHIF, our National Hospital Insurance Fund here in Kenya. It also took care of part of it. Then it reached a point, it also went off. So that's when I reached out now to my family members. My family members, they came in, had all of them, my brothers, my sisters, my nephews, my nieces, and even my friends. I involved them and they all came in handy and contributed, and I was able to go through the treatment. And then also something else that I had some savings. So I put on the savings in it, because when you're going through this journey, you feel like you are becoming a burden. That is very normal and very common. You feel like you're becoming a burden to the family, your friends, and everybody. They have contributed, they have given you their space, they have given you their time and everything. So my savings, I chipped in. And in fact, I had a car. I wanted to sell it, but I was told by my family, no, you are not going to sell the car. Keep it for future, because you are going to get well and continue working. So the car was preserved, by my savings went into the treatment. And so if I would have done something differently before the diagnosis, it was about having more savings. It's about having it. I don't know whether we don't plan to get sick. We don't predict we are going to get sick. But if somebody is able to put like a kitty or have more an insurance, a better off insurance, maybe it could save you a lot of hassles. And but also I would urge the government also to cover more on cancer, because the drugs are not cheap, the tests are not cheap, the when you go for checkups, it is not cheap. Like now it has gone, I used to pay from 3, now it has gone to 4,400 just a consultation. And the tests, the MRI, the doctor has talked about, the CT scans, the blood works, the ultrasounds. And also because of the tamoxifen that I take, I also have to do an ultrasound of my uterus. So it is not cheap. So if somebody would have put more money, if I would have maybe more savings, it would have saved me. I usually tell people, when I was going back after having worked like for maybe 15, 14 years, I went back with an account of 10,600 shillings back to work. My savings went, everything went. I had to restart afresh. But you know what? You start afresh knowing that you are going to get better and you are going to get well. So the monetary aspect is not cheap, it is not easy. But if the government can come in and support more on the cancer journey, cancer treatment, it can take away a lot of stress from the patients and the relatives' mind.
Thank you so much, Rose, for that very heartfelt and passionate appeal to those in positions of power who are able to make laws and bring in insurance covers that are able to help those patients who might not be able to take care of the financial aspect of treatment and even diagnosis. So we're almost winding up. I wanted Dr. Kwaj to answer some of his questions before we head to challenges and lessons learned and conclusions. Dr. Kwaj, I'm not sure, Aisha, I wanted you to tell me whether the audience can hear Dr. Kwaj because he's currently on WhatsApp. I've just put him on loudspeaker. So please inform me if they're unable to hear. So Dr. Kwaj, what I was asking you initially is what is the public health impact of breast cancer, and what are some of the public health strategies that have been used in prevention? How can some of this be implemented in South Sudan or even sub-Saharan Africa in general? Dr. Kwaj, go ahead.
Thank you, Anne.
Yes, go ahead, Dr. Kwaj.
Okay, then, sorry for this technological,
We can't hear Dr. Kukwaj.
Sorry, Dr. Kwaj, just go ahead. I think I was on mute. Go ahead. Sorry.
Yeah.
Please start from the
Right.
beginning. Yes, go ahead.
Well, I just stated that let us just look at the data from the World Cancer Report 2020. The breast cancer has surpassed the lung cancer for the first time, and now is ranked number one with new cases of 2.3 million and almost something like 685 deaths. So this is the extent and the magnitude of the breast cancer in the world. If you look at the African continent, we are ranked fifth, contributing 8.3% of the breast cancer total global load, which is around something like 186,589. With the death, we are ranked third, almost something like 12.5%, which is also 5,787. And this proportional high death is attributed to late stage representation, lack of access to high quality breast cancer services, which also translate to something like 46%. That to say, almost 1 in 2 women diagnosed with breast cancer died in 2020. So this is just the snapshot. In South Sudan and in most of the low and middle income countries, because of inadequate data, and then the data that we have also is not reliable, the quantification of the magnitude of the disease therefore become very difficult. So the published data by the Global Cancer Observatory for South Sudan are estimates derived from our neighbor countries or regional national cancer registries. So for us, we have, according to them, or according to what estimate that was put for South Sudan, we have, the total new cases of 916 and mortality of 554, and we have something like 1,438 women living with breast cancer for the last 5 years from the diagnosis. So this is just in short the snapshot of the impact of the breast cancer in the world, at the regional level, and even in our country. So now moving to some of the preventive strategies which are used, worldwide. The best strategy to prevent any disease is actually, to prevent it from occurrence. And the breast cancer goes even beyond the prevention to avoiding unnecessary death. So one of the most effective way of preventing is to identify those with breast cancer at the nascent stage. Like that one that was just shared by Rose is stage 1. But if you can even get it, to less than that, that will be much more better, because the treatment is cheaper, and then also, the financial burden on the patient will be even more less, and the outcome is favorable. So this one, which is the public awareness of the breast cancer, it includes the risk factors as well as its signs and symptoms, followed by the early detection, diagnosis, and appropriate treatment. These are the measures that are now the gold standards. But using these public, are you getting me?
Yes. Go ahead, Dr. Kwaj.
So the public health awareness is the gold standard for any setting, being high the developed world, or even in our setting here, which is the less or developing world. So people know exactly what is the breast cancer, what are the risk factors for them to avoid it, and what are the signs and symptoms for them actually to go for early detection and then diagnosis and appropriate treatment. The public awareness also has an inherent effect of reducing fear and stigma. We heard from Rose that hearing that the breast cancer is actually sent a shockwave, that you are dying and it's not curable, stigmatized and all this. So through the educating the population, you will debunk some of the myths and conceptions about the breast cancer, which can even lead to increased health-seeking behavior.
What are some of these myths and misconceptions that people have about breast cancer, and how can we sort of get it out there that these are not true, and what are some of the reasons that you have seen affect those who possibly have breast cancer but do not seek medical attention, and what can be done about that?
Well, breast cancer is like any other disease in the world. It has just a lot of mythical perceptions about it. But in our context here, according to finding from the knowledge, attitude, belief, and practice studies, it shows that in Africa, most of the people believe that breast cancer is just a witchcraft or is a curse, or sometimes some of them think that breast cancer can be acquired by contact with the patient who has the breast cancer. This is at the level of people who have no education. Then you move up, the ladder. The second thing is some of them, they think that breast cancer is just running in certain families. It's like a family disease. While we have even heard from Dr. Kendan that the familial breast cancer constitutes something like 5 to 50% of all cancer. So you have almost something like 80% which are sporadic, are not genetically inherited. The fourth one is wearing a bra. Some of misconception and the myth is like whoever wear a very tight bra can cause also the breast cancer, which there is no any evidence about it. Some people think that breast cancer is only affecting women, which is not true. We also heard from Kendan that at least something like 5 to 1% of men are affected by breast cancer, but it is predominantly skewed towards females. Some of them think that having huge breast mass is like a recipe for a cancer, which is not true, although it increases actually your risks for getting the breast cancer compared to people who have a lean breast mass. So this is due to over stimulation by estrogen and other hormones.
Mm-hmm.
And the last thing, which also, causes fear, is what I mentioned before, and this is the most misled part of it, is that it is a curse and then cannot be helped medically.
Mm-hmm.
You have to go to healers, which is not also, true. It's a disease like any other disease. It has a medical and evidence, foundation, and is also curable.
Mm-hmm.
So these are some of the myths that I can just share with you.
Mm-hmm. What are some of the reasons that those who are affected do not seek medical attention from what you've come across?
Well, from the cross-sectional qualitative studies and operational research, most of the reasons, and they divide into two, which is patient or demand side, and then the other one is a provider, which is the supply side. From the patient side is awareness, which is the key.
Okay, thank you, Dr. Kwaj. Yes, you have actually, sorry, we'll try and reconnect to you in a bit. Seems Dr. Kwaj has dropped off. I was going to start to ask him about, yes, Dr. Kwaj, you had dropped off a bit. You are telling us about some of the reasons.
Yeah, some of the reasons. Number one is actually, is the basic knowledge about the breast cancer. You see, lack of awareness. Most of the women who come to the clinic with the late stage, they don't have any knowledge about the breast cancer. So the awareness about the breast cancer, signs and symptoms, and then where to report is really very important thing. Number two is the finances. You know, in our context in particular, the breast cancer services, we don't have them in public hospitals. So most of the these pathologists, whoever that are in private sector, and then if you don't have, a very sound health financing system that has financial protection attached to it, like having, the health insurance, then most of the people, they actually don't have, that ability to access those services. 50% of the cost, according to some of the research, goes also, for logistics. In our country, we have a problem of the coverage. Almost something like 44% of the population are covered by the primary healthcare services. Hospitals, surgeries are just located in big cities. So the masses of the population that are in rural areas, they don't have access to such service. So logistically, for them to come from I don't know where to Juba, they need to be transportation, feeding, all these things, and it also to the cost of service fee. So then you have, as I said before, you have also a fear of treatment. You know, some of the women, they fear because the breast cancer actually touches some. I'm not trying to be misogynistic, but it touches actually some of part which is to women.
Yeah.
So imagine that you being told now that you are going, if you go to the clinic, the first thing that they do, they will chop out you are what you are breast. This one is also one of the things that can also prevent some of the people to go. This is just from the supply, from the demand side, from the patient side.
Yes.
Side, the big thing is the lack of access to the breast cancer services. And I mean that you don't have any services for the breast. Cancer, all that there, but there is no any financial protection. Secondly, you have poor organized without proper referral. And it also causes because, like close, for instance, if now she has detected that she has a breast lump, all right?
Yeah.
And then from where she got it, then she needs to be transferred to the higher level of healthcare services. If there is no any clear referral path, she will just drop out and get lost in the middle because she doesn't exactly where. You need a dedicated centers for the breast cancer services, which is really, really very important. And then training of the health the health workers. You really need a who are trained on how to examine the breast cancer is really very important. Even surgeons. I've heard, my sister talking about, sampling and all these things. You also need somebody who will take satisfactory and, an accurate sample that will, or adequate sample for the pathologist to do the test. So these are some of the things that also, deter people to report it.
Thank you, Dr. Kwaj. I'll come back to you a bit about some of the public health options available for financing and suggestions for improvement of services. We need to let Dr. Beryl go, so I want her to give us an overview of some of the challenges that she has encountered in the management of breast cancer in the African/Kenyan setting, and what some of her recommendations are before she leaves the panel. Dr. Beryl.
Thank you very much. Part of the challenges Dr. Kukwaja has already mentioned. One is public awareness of breast lumps, and the public means both male and female. If you have a breast lump, then you need to see a doctor. And once you see a doctor, then you need to follow through with the care. The other challenge is finance, and that's Rose mentioned. For us to diagnose a breast lump, whether it's benign or it's malignant, as Dr. Melvin had mentioned, you have to go through a series of tests. That takes quite a bit of money, just in the diagnosis part, then to follow up with care. So from public health, I think we need to invest more into cancer diagnosis and cancer treatment. That would be very helpful to most of our patients, because you get almost catastrophic deaths coming just from cancer treatment. And most patients do not do well because they can't afford care. The other challenge is availability of treatment options. I'm so sure the situation in South Sudan is worse, but even in Kenya, not everyone has access to radiotherapy. Not everyone has access to an oncologist. So one of the ways we can mitigate this is one, public health awareness, and number two is the government investing into cancer care. I don't think individuals should be able to bear that burden on their own, because it's a huge burden. So the government investing and taking part of that care would be useful. In conclusion, I would say that breast cancer is treatable. It's one of the good cancers because there's cure for it. But you have to get to hospital early so that you'll be thriving like Rose. So we want more people who are thriving. We don't want people who are dying from breast cancer, because we know it's treatable. I think in Kenya, there are various ways that you can be helped, especially if you come to Kijabe. Even though you don't have the funds for it, you can come or refer patients, and we can see how we can help you. Thank you very much, and thank you for having me.
Thank you so much, Dr. Beryl, for taking time out of your, I'm sure, very busy schedule. And we are so grateful to have had you on the panel. And we are honored to have been able to learn from you, especially about the treatment aspects and some of the challenges, and also get some solutions for you. And thank you for the information that for those who are able to get to Nairobi, they can actually be seen in Kijabe, and you will work out ways of assisting them in case they're not able to go through the treatment in terms of financial issues. So thank you so much for that. And I'm sure a lot of people have heard you. And for those in East Africa, then this is very important information. And even for those in South Sudan who are able to access services in this country. So thank you so much. And we'll release you. And thank you for being on the platform today. We are so grateful, Dr. Beryl.
Thank you very much.
Okay, thank you. And as we let Dr. Beryl go, we'll go back to Dr. Kukwaj. I know Dr. Beryl has said a little bit about financing for breast cancer treatment. What are some of the other options you would advance in terms, if you're speaking to people who can actually make decisions on it, what public health options can be available for financing? Which of them would work in South Sudan? And from a public health perspective, what suggestions would you give for improvement of services for breast cancer? Dr. Kwaj.
In terms of health financing, I think the more effective way to finance is to get, a sizable government investment in the health sector, which is really very important, because some of the breast cancer services can be also found in the normal setting of the health services. So you don't need to establish, a vertical program, which is very expensive, and then it also, fragment, the health services. So the first thing is we need to encourage the government and advocate for increasing the allocation, to the health sector. Currently in South Sudan, we have something like around 2 or even less, 2% or less of the annual national budget. And this one is far below, the continental commitment that was made in Abuja in 2001, which is 50% of the annual national budget has to be allocated, for health sector, for us to have at least essential health services. So number one is we need to advocate for our government to increase, the investment in health sector. Number two is what we call, pooling. We know whatever that government is going, to put in the health sector will not be enough to cover all the aspects of the health sector continuum. So you need actually, to put some sources of income. And one of them, like what has been mentioned in Kenya, is a national health insurance that will provide financial protection, and then will also promote the equity and accessibility to those health services. So this is number two. Number three, having money in the pocket, you also have to have a strategic purchasing of health services. We have heard that even when you go to the cancer care center, some of the investigation, some of medicine, some of the imaging, and even the radiotherapy are not available. You have to pay out of your pocket. So government should actually look at these things and invest in them. At least purchase them from whatever, being government facility or being a private facility. You have to prioritize things that address the diseases in people who are poor, to provide financial protection, so that you also avoid having a portion of your population going to the poverty. So this is just the three things that I think will make a sound financing, health financing in the country.
Thank you so much, Dr. Kwaj. You can go ahead and give us your conclusion, and then Dr. Melvin will say a little bit about the challenges in terms of pathology and diagnosis and give us her conclusion. And then we'll end up with Rose, who will give us some of the lessons learned, and also just talk to the audience as a final word. So, Dr. Kwaj, what is your final conclusion / recommendation? Maybe 1 minute.
Well, one thing which is very important, looking at our national health policy, the health sector strategic plan, and all the assessment that was done into the health facilities, there is no any breast cancer, priority activities which are there. So number one, we actually need a comprehensive national breast cancer control plan. So this is the number one. That will give us, the gap analysis with clear, realistic objection, and then evidence-based intervention. This is number one. Country should have a roadmap on where it is and where does it want to go? Number two, you need a separate strategy for early detection and treatment. This is very important because, as we heard a lot, that if breast cancer is treatable and is cheap, if it's detected early and then treated appropriately.
Yeah.
Number three, you need a robust national cancer registry, because for the planning purposes, you actually need data. So our DSIS is skewed towards infectious diseases, and then those non-communicable diseases, if you look at how data is recorded, is not helpful. Then I also look at we need to have some sort of national cancer institutes. This one will help you with research, training of the specialists, and even you can station some of the high-tech cancer equipment like radiotherapy, MRI if you don't have money, things of that kind. All right? So is the thing that we really as a country, for us to improve cancer care, it might be something that we may need actually to look at. Thank you.
Thank you so much, Dr. Kwaj. I like your suggestions, quite comprehensive. And I hope the people who are in the Ministry of Health and those who can make decisions on this are listening, because I think those are very, very viable solutions and recommendations that you've given there. So thank you so much, Dr. Kwaj. We are sorry about the internet issue, but we are so glad that you are able to join us on WhatsApp and have been able to give out the information that we needed. So thank you so much for joining us and for being on this platform, and we are grateful for your time.
Thank you,
Thank you. So I will now go to Dr. Melvin. Dr. Melvin, if you can just give us a brief note on some of the challenges encountered in the African setting by pathologists in diagnosis of breast cancer, and give us some of your recommendations and your conclusion before we end with Rose. Dr. Melvin.
Okay, some of the challenges we usually encounter is social barriers to early diagnosis. So this usually affects women who are in the village. Before they come to the hospital, they have to seek permission from their husband, and that will take forever. And by the time you get to diagnose its cancer, it has already progressed to maybe stage 3 or maybe stage 4. Then also part of the social barriers is women fear that if they are diagnosed with breast cancer, they might lose their jobs, lack of employment. So they'd rather stay with their issues rather than going to the hospital for early diagnosis. Then the other one, as we've already said earlier, maybe social taboos of cancer and the misconceptions that follows the treatment and the diagnosis. So my recommendation is health education should be accessible to all, as in especially the women in the grassroots levels, the ones in the villages. They should be educated on what is breast cancer, what should be done, how is it diagnosed, and early detection is usually the best possible pathway to take. Then one of the things we might do is do radio broadcasts, do television broadcasts, write leaflets and pamphlets informing people about breast cancer. You can also educate the men who are, I'm putting it in quotes, supposed to give permission to their wives to go to the hospital. Educate the men so that they may also know breast cancer. Early detection is usually the best possible pathway. So my conclusion is early detection by screening usually identifies the invasive ones and the non-invasive ones, and it can also help in finding the best possible treatment modality and increases the chances of survival. Thank you.
Thank you so much, Dr. Melvin, for that. And thank you for joining us. Don't go off the screen. We will go to Rose. Rose, maybe you can just give us a brief overview of some of the lessons that you would like to share with the audience, and a conclusion and a last word. We are so grateful to have had you on this panel discussion. Rose. Rose, you're on mute. If you can unmute yourself. Thank you. Go ahead, Rose.
Yes, sorry. Yeah, First of all, let me say a lot of thanks to you people, because you're mentioning there is breast cancer in men. That one is rarely mentioned. And Doc, I know you have been following me, I usually conclude my discussion and awareness on breast cancer. Men can also get breast cancer. So thank you so much for highlighting that. Now, my concluding points and the lessons that I've learned is early diagnosis is the key. Once cancer is caught early, you are able to survive. The prognosis is good. The treatment is a bit cheaper, in quote unquote, and it's not long. It is not going to be a long journey for the active part of treatment. Number two, it's information is power. If I got I felt the lump and I went straight and I sought help immediately. If we can give the right information to the communities and to that woman down in the village, that if you feel a lump and you rush to the hospital, you are going to be saved. You are in a better position. So that is something that I've also learned. Something else is, let's give hope. I've always said I want to be a face of hope. I want to be a face of encouragement. I don't want to just say, oh yeah, the pity party corner. No, I want to tell people that there is life after cancer, and your life moves on. If you had the goals, if you had something you had set up, please continue having your goals and your dreams, because there is life after cancer. The other thing is, women know you are normal. If you don't know your boobies well, if you don't know your breast well, then if something abnormal happens, you are not going to know. So know you are normal so that you know they are abnormal. If I didn't know my boobies well, then I feel something, I would have just settled there. But know you are normal so that you know when the abnormal happens. The other lesson is, women, from the rooftop, not all lumps are cancerous. Don't fear. Some lumps, as our Dr. Melvin has said, they can go and they are benign. So please, when you feel a lump, don't say, oh God, it's cancer now, I'm going to die, and you sit in the house. There is something we call cancer does not sleep. Cancer eats you every day. As you sit there waiting and wishing and hoping, it is spreading and it is growing. Not all lumps are cancerous. So once you feel a lump, please go to the hospital. The other thing is, if there is history of breast cancer, as we have been told, especially from your maternal side, your mom, your sister, your auntie, your grandmother, please schedule your mammogram as early as you can. Then with those results, they will schedule accordingly. If there is something, if not, you are going to be scheduled accordingly. The other thing I've learned is, there is life and there is hope beyond cancer. Yes, please don't feel discouraged. Whether you are told you have cancer, you are not going to die. I usually say, and I write, cancer was just a chapter in my life. It is not my whole story. So my whole story, I'm continuing to edit it, because God has the final say and has the last chapter of my life. So God bless you and keep well, and thank you so much for this chance. And whenever you ever need somebody to hold your hand, please don't feel free to get in touch with me. I hold hands to people all over the world. My friends, my family connect me with people, and I hold their hands. We walk together and we complete treatment and we celebrate as we ring those bells. So please reach out to me. You can go through Dr. Lomole. I'm available for anybody. I am here to give hope and to say cancer is no longer a death sentence. Thank you.
Thank you so much, Rose. You almost got me very teary-eyed at the end there, and thank you for advancing a helping hand and saying that you will be available for anyone who needs a helping hand. I don't think I have much to say after that conclusion. You've all been amazing, and thank you so much, Rose, for encouraging us and showing us what it takes from the perspective of someone who has actually gone through the journey. I know for a lot of cases, as doctors and as medical professionals, we tend not to be able to put ourselves in the shoes of our patients and the people who are affected. But when we have people who have both sides of the story in terms of the medical aspects and also the actual experience, then it's easier to actually be able to give information to those who are going through a similar situation. And I'm so grateful that you are here on this panel, and I hope to have you soon again to discuss the same or other aspects of care, medical care, even not necessarily breast cancer. So thank you so much for joining us, Rose. Thank you, Dr. Melvin. Thank you, Dr. Kanyang in absentia. Thank you, Dr. Beryl. And thank you, Dr. Kupaj. And I would like to thank Aisha, who's behind the scenes with technical support. And I thank the audience for joining us today. I hope it has been an eye-opening discussion for you. And remember, as Rose said, there is life and there is hope after cancer. Check yourself, get an early diagnosis, get treatment started early, and who knows what the world may bring you after that. And we hope that all of you are encouraged today. Thank you so much, Rose and Dr. Melvin, for being with us until the end. And I'd like to say goodbye right now to the audience. And we hope to see you soon again in our next discussion next week on Saturday on the South Sudanese Women Intellectuals Forum. So thank you and goodbye. Thank you so much.